वासनी सर भी ज्वाइन हो चुके हैं।
हाँ, वासनी सर नमस्ते।
नमस्कार सबको, नमस्कार।
सर अतुल सर।
जी जी।
हाँ, शुरू कर दिया क्या?
हाँ हाँ, आप तो कंटिन्यू करो। धन्वंतरी बनना होगा ही क्या?
नहीं, अभी होनी है सर, अभी करेंगे।
हाँ, वो कोई ना कोई जरूर कर ले, है ना।
हाँ जी, हाँ जी, करते हैं।
आज पार्टिसिपेंट ज्यादा है, अच्छा लग रहा है। 3 से ज्यादा इस समय है
सर मंगलेश सर के स्टूडेंट्स भी है।
हाँ हाँ हाँ, अच्छा है।
हाँ, यहाँ पे भी बहुत बच्चों को मैंने शेयर किया था तो बहुत सारे आए हैं आज।
अच्छा,
मंगलेश
नहीं
सर का
बढ़िया है।
जलवा है, मंगलेश सर का जलवा है, इसलिए इतनी रौनक है आज।
हाँ, वही मैं कहना चाह रहा हूँ, अमरनाथ जी ने कह दी मेरे मन की बात। सही है।
चलो सर, थैंक यू फॉर कॉम्प्लीमेंट।
सर पहले धन्वंतरी वंदना कर लेते हैं, फिर मैं इंट्रोडक्शन कर दूंगा।
ठीक।
नमामि धन्वन्तरि आदिदैवम् सुरासुरैर्वन्दिते पादपद्मम् लोके जरारुग्भयमृत्युनाशनम् दातारमीशं विविधौषधीनाम् आर्तानां विविधैर्गदैर्विभुविपरित्राणाय वातरत् पाणिभ्यां निखिलामयान्तकसुधा कुम्भं जलौकां ददौ।
हाँ सर, आवाज नहीं आ रही?
हेलो। हाँ प्रशांत जी, शुरू कर दीजिए।
हाँ हाँ,
हेलो।
हो शुरू कर दे। धन्वंतरी वंदना कर दे।
नमामि धन्वन्तरि आदिदैवम् सुरासुरैर्वन्दिते पादपद्मम् लोके जरारुग्भयमृत्युनाशनम् दातारमीशं विविधौषधीनाम्
हेलो।
आर्तानां विविधैर्गदैर्विभुविपरित्राणाय पाणिभ्यां निखिलामयान्तकसुधा कुम्भं जलौकां ददौ। अङ्गैर्यकृपया स्थिरैर्शरतो जीवेम सौख्यात् शतम् वन्दे वैद्यजगतगुरुं कम्पितं धन्वन्तरिं सादरम् शङ्खं चक्रं जलौकां ददत अमृतं घटं चारुदौर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्धं शुकपरिविलसं मौलिमम्भोजनेत्रं कालाम्बोधोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यम् वन्दे धन्वन्तरिं निखिलगदवन प्रौढभावाग्निलीलम् ॐ शान्ति शान्ति शान्तिः।
Welcome all of you. Welcome all of you. सर डॉक्टर प्रशांत देशमुख आज हमारे एकेडमी ऑफ रोग निदान लेक्चर सीरीज के हमेशा की तरह सैटरडे को जो लेक्चर सीरीज होती है उसका एक लेक्चर है। आज सबसे पहले मैं एकेडमी ऑफ रोग निदान की तरफ से प्रोफेसर राजेश मंगलेश सर को बहुत बहुत अभिनंदन करना चाहता हूँ कि वो अभी इसी महीने एज अ प्रोफेसर प्रमोट हुए हैं। आयुर्वेद में प्रोफेसर की पोस्ट तक प्रमोट होने के लिए बहुत समय का इंतजार करना पड़ता है और बहुत समय के इंतजार के बाद आखिरकार राजेश मंगलेश सर को उनकी इतने सालों की मेहनत का पुरस्कार के तौर पर उनको प्रोफेसर के पद पर प्रमोट हुए हैं। उनका इंट्रोडक्शन करने का आज मुझे सौभाग्य मिल रहा है। सबसे पहले मैं बताना चाहता हूँ कि मैं उनका उनके अंडर जो पीजी शुरू हुई थी उनके सेकंड बैच का स्टूडेंट था और उनका मैं शिष्य रह चुका हूँ और मुझे आज उनका इंट्रोडक्शन करने का सौभाग्य मिला, इसलिए मैं बहुत अपने आप को सौभाग्यशाली मानता हूँ। राजेश मंगलेश सर ने BAMS ग्रेजुएशन, वो हिमाचल के रहने वाले हैं, और जब गवर्नमेंट आयुर्वेद कॉलेज था, जब PG इंस्टीट्यूट नहीं था, तब उन्होंने गवर्नमेंट आयुर्वेद कॉलेज पपरोला हिमाचल प्रदेश से अपना BAMS किया। उसके बाद BAMS कंप्लीशन के बाद उन्होंने 1989 में अपना खुद का क्लिनिक शुरू किया। क्लिनिक शुरू करने के बाद 1992 में वो हरियाणा के पब्लिक सर्विस कमीशन के थ्रू मेडिकल ऑफिसर नियुक्त हुए। मेडिकल ऑफिसर होने के बाद उन्होंने 1998 में आज जो एक वर्ल्ड ट्रेडिशनल सेंटर, जहाँ ट्रेडिशनल मेडिसिन का सेंटर जहाँ खुला है, ITRA जामनगर, तब वो IPGTRA जामनगर था, वहां पे उन्होंने रोग निदान के अंदर PG की और 2001 में पास आउट हुए। 2001 में पास आउट होने के बाद वो हिमाचल प्रदेश में राजीव गांधी पोस्ट ग्रेजुएट आयुर्वेद कॉलेज में एज ए लेक्चरर नियुक्त हुए। 2005 में एज ए सीनियर लेक्चरर वो प्रमोट हुए। उसके बाद 2012 में एज ए रीडर वो प्रमोट हुए, और 10 साल बाद 2022 में अभी एज ए प्रोफेसर प्रमोट हुए। मैं अपने आप को और पूरे एकेडमी ऑफ रोग निदान को बहुत सौभाग्यशाली मानता हूँ कि जब एकेडमी ऑफ रोग निदान शुरू हो रही थी, तो ये हमारे स्टार्टिंग जो सदस्य होते हैं वहां से उन्होंने हमारे साथ जुड़े हुए हैं। वेलकम राजेश मंगलेश सर। Sir, now you can continue with your lecture. हेलो
हेलो।
हाँ जी सर। सर की आवाज नहीं आ रही है।
सर आप लेक्चर शुरू कर सकते हैं सर। सर प्लीज अनम्यूट योर सेल्फ। हेलो हेलो सर प्लीज अनम्यूट योर सेल्फ।
सर राजेश सर। हाँ जी सर, अब आ रही है आवाज।
आ रही है?
हाँ जी सर।
अच्छा ठीक है। First of all, thank you, Dr. Prashant, introducing me with the रोग निदान अकेडमी। और मैं विशेष धन्यवाद भी करना चाहूँगा कि आप लोगों ने एक लेक्चर मेरे लिए प्रेजेंट करने का मौका दिया। Thank you all. Now I am starting my topic, that is the liver function test and its interpretation. As you know, first, the liver is the largest internal organ. Though skin is the largest organ, but it is external organ. The liver is the internal organ which is the largest, weighing 1.5 kg, and it is located in the right hypochondrium, just starting from the 5th rib to the lower border of the rib cage. The liver extends up to the epigastrium and has two lobes. right and left separated by the ligament falciparum. Though there are two lobes, physiologically they are same. Each lobe, again, it is divided into 8 lobes, and there is totally 16 lobes. These 16 lobes further divided into lobules. The situation is categorically very interesting. It is very interestingly placed in the abdominal cavity. It is the only organ which has two supply. One that is from hepatic artery and other that is from hepatic portal vein. And there is also two exits. One is the hepatic vein and other is the liver excretion of the liver canaliculi, bile canaliculi, that is the bile duct. The lobes of the liver are made of lobules that contain hepatic cells, sinusoids, and the Kupffer cells. Bile is secreted by the hepatocyte, passes through the canaliculi to the bile ducts and joins with the cystic duct, and finally through ampulla of Bator empties into the second part of the duodenum through sphincter of Oddi. The working cell of the liver are known as hepatocytes, which have a unique capacity to reproduce in response to liver injury. This is very characteristic of the liver. Liver generation can occur after surgical removal of the portion of the liver or after injuries that destroy part of the liver. Although the liver ability to react to damage and repair itself is remarkable, repetitive insults can produce liver and failure and death. Microscopically, as I earlier told, units that divide liver responsible for all metabolic and excretory functions. There is 6-side structure with centrally located vein and portal tracts. I will explain in this diagram. The portal vein collects all the nutrients absorption from the intestine, joins with the splenic vein and pancreatic vein, commonly known as planchic vein, and comes to the liver. The branch of hepatic portal vein has been shown, and it joins with the branch of hepatic artery in a sinusoids. These are known as hepatic sinusoids, and then these are collected into the central canal blood flow out of liver from hepatic when it goes out. Another, there is bile canaliculi. From there, the excretion of the bile goes and collected in the bile ducts and drains into the intestine. The hepatocytes, Kupffer cells, hepatic sinusoids, branch of artery. In the next diagram, I will explain. So when these sinusoids are fenestrated, so the things can pass, goes out and comes in. So this is about the supply of the livers. Then the objective of the liver function test. First is that to understand the major metabolic function of the liver and cause of liver dysfunction, and to discuss the marker of liver function tests such as liver enzymes, bilirubin, albumin, and prothrombin time that can diagnose hepatic injury and assess hepatic functions. Function of the livers. To understand the liver function test, we should have the knowledge of the function of the livers, what the liver plays its role in human body. These are categorized as metabolic function, excretory function, synthetic function, detoxification function, storage function. First is the metabolic function. Liver is the principal site where the metabolism of the carbohydrates, lipids, and protein take place. Ammonia is converted to urea, cholesterol is synthesized and catabolized to the bile acids and bile salts. The esterification of the cholesterol is solely taken place in the liver. The absorbed monosaccharides other than the glucose are converted into glucose, for example, galactose and fructose. These are converted into glucose in the liver. Also involved in the metabolism of vitamin and minerals to some extent. Then comes the secretory function. Liver is responsible for the formation and secretion of the bile in the intestine. Bile pigments, bilirubin formed from heme catabolism is conjugated in liver cells and secreted in bile. Certain exogenous dyes like BSP and Roswengel dye are exclusively excreted through the liver cells. The liver plays important role in synthesis of many components. These components, plasma proteins, albumin is solely synthesized in the liver. The globulin, especially alpha and beta globulin, are synthesized in the hepatocytes. The clotting factor like 5, 7, and 10 are also synthesized by the liver cells. Synthesis of fibrinogen involved in the blood coagulation also takes place in the liver. Synthesis of cholesterol, triglycerides, and lipoproteins. Besides these, many other complement proteins, acute phase proteins, C-reactive proteins, and many other materials are also synthesized by the liver. Detoxification and protective function. Liver plays important role in the detoxicating the drugs, hormones, and convert them into the less toxic substances. Kupffer cells, which are also known as macrophages, remove foreign bodies from the blood by phagocytosis. As earlier said, the all intestinal absorption first comes into the liver, then goes to the other part of the body. So liver plays very important role in this case, detoxification and protection. The unwanted material are taken by the Kupffer cells and they are degraded, and drugs and other toxins are detoxified. Then next function, that is the storage function. Liver stores many components inside it. Main is the glycogen. The excess of glucose is converted to the glycogen and is stored in the liver for future use. The vitamins A, D, E, K, and especially the vitamin B12, iron, copper, manganese, these are all stored in the liver. Now, what are the LFTs? That is liver function test. In order to evaluate the liver disease, the serological measurements are done. The term liver function tests are actually a misnomer because the serological measurement, not only the function of the liver is evaluated, but damage of the hepatocytes, hepatocellular are also done. Serum aminotransferase, that is ALT, AST, reflects the inflammatory condition of the liver. Alkaline phosphatase reflects the biliary injuries. Bilirubin, albumin, and PTINR more accurately reflects the hepatic functions. Why are LFTs ordered? These are ordered for 4 things. For routine checkup, a patient come to the clinic, the clinician in routine ask for LFT, RFT, lipid profile, other hematological tests also. So for routine checkup, drug monitoring, if the patient is consuming drug for some purpose, the bad effect the body is having. So these are also detected in the test, liver function test, OTPT especially. The symptoms, the hepatocellular problems are diagnosed through the LFTs, the screen for the liver disease. So these are the factors for which the LFTs are ordered. Now, the test, there are some bases with which the tests are ordered. The test based on the excretory function. These are serum bilirubin, urine bilirubin, urine and fecal urobilinogen, urine bile salts, dye excretion tests. Then the detoxification functions. The hypuric acid test is done. The determination of the blood ammonia is called. To detect the synthetic function, the plasma proteins and protein time is estimated. Enzyme in diagnosis of liver disease. The serum transaminases, AST and ALT, alkaline phosphatase, gamma GT, 5 nucleotidase. These are ordered for to detect the liver injury or liver diseases. This is another classification of liver function test. These are grouped in 3 groups. The first group, marker of liver dysfunction. These are serum bilirubin, total conjugated and unconjugated, urine bile pigments, bile salts, urobilinogen, total protein, serum albumin globulin ratio, prothrombin time. To detect the hepatocellular injury, the markers are ALT, that is SGPT, or AST, SGOT. Markers for cholestasis, alkaline phosphatase, gamma GT, 5-nucleotidase. These markers are ordered to know the dysfunction or the hepatocellular injury or the cholestasis. Then the test based on substances released by the damaged hepatocytes. These tests are separated in 2 groups. Endogenous compounds released by the damaged cells. The hepatocellular cells have enzyme AST and ALT. On destruction or injury or infectious disease in inflammation, these enzymes are released in the blood. The endogenous compounds synthesized at the increased rate or released by the canalicular membrane, bile duct, epithelium and endothelium of central and peripheral veins. The tests required are ALP, GGT, 5-nucleotidase. Then the test based on substances cleared from the hepatocytes can be separated into 2 groups. Endogenous metabolites, bilirubin, bile acids, and ammonia are cleared by the liver. The exogenous compounds, the drugs, aminopyrin, lidocaine, indocyanine, etc. These are cleared by the hepatocellular cells. These are some examples of the liver dysfunctions: hepatocellular disease, cholestasis, cirrhosis, hepatitis, jaundice, liver cancers, fatty liver, genetic disorders, hemochromatosis, that is iron storage. Then biochemical parameters in the LFT are again same: bilirubin, ALT, AST, ALP, GET, 5-nucleotidase, serum plasma albumin, total protein. Among these, GGT and 5-nucleotidase are not common, but other tests are commonly prescribed for the liver function or liver damage. Then again, a classification of LFT according to the function of the liver. These are tests based on the excretory function, tests based on the synthetic function, tests based on the metabolic function, test based in storage function, test based on detoxification function. The first, that is the test based on abnormalities of the bile pigment metabolism. Total serum bilirubin, ESB, IDSB, urine bilirubin, urine urobilinogen, fecal urobilinogen. These are the common tests to detect the bile pigments and ordered in case of jaundice. The first, that is the serum bilirubin. Total serum bilirubin value, as you all know, is 0.3 to 1.2 milligram per deciliter, from which direct bilirubin is less than or equal to 0.4 milligram per deciliter, and indirect 0.3 to 1.2 milligram. How the bile metabolism takes place? As you all know, the RBCs, when broken, from that metabolism the bile is produced. How? The lifespan of the RBC, all of you know, that is 120 days. The senile cells or the other cells which have different shape are taken up by the reticuloendothelial system, that is mainly the spleen. The macrophages takes these, it captures these RBCs and degrade them into heme and globin. Globin part is released. The heme contains the iron and biliverdin. The heme oxidize it to biliverdin. Then biliverdin reductase, with the help of a NADPH, convert it into bilirubin, and this bilirubin binds with the albumin, and this component is water insoluble. It is also called as unconjugated bilirubin. This unconjugated bilirubin comes to the liver through the portal vein. Through portal vein is joined with the splenic vein and the pancreatic vein and comes to the liver. This unconjugated albumin bound bilirubin is taken up by the ligadins of the hepatocytes, and albumin is separated and the bilirubin is conjugated, and glucuronide to the conjugated form, bilirubin diglucuronide. This bilirubin, conjugated bilirubin, now it is water soluble and is excreted to the bile duct to the intestine. In intestine, this bilirubin is further acted upon by the microorganism in the gut and converted to the urobilin or urobilinogen. Oxidation takes place there. 80% of the urobilinogen is excreted with the feces. This is gray or yellowish in color and gives the color to the stool. 20% of the urobilin is reabsorbed and is excreted through the kidney. So fate of the bilirubin from the broken up the RBC to the urobilinogen. These are three phases: before the liver, in the liver, and after the liver. So pre-hepatic, hepatic, and post-hepatic. This is another diagram. I have explained it. Now, the normal range I already discussed. Total bilirubin 0.2 to 0.8 milligram, conjugated 0.2 to 0.6, unconjugated 0.2 to 0.6, conjugated bilirubin 0.2 milligram. If the plasma bilirubin level exceeds 1 milligram per deciliter, the condition is known as hyperbilirubinemia. And if it goes to 2 milligram per deciliter, it is the indicator of the latent jaundice. After the 2 milligram, it starts appearing in the sclera, skin, mucous membrane. Jaundice appear there is, and condition is known as icterus. This is the method to estimate the bilirubin. Old method, now the bilirubin total or direct, indirect is estimated in the automation, but the principle is same. Direct bilirubin plus diazotized sulfonilic acid is converted to isobilirubin. Indirect bilirubin reacts with the diazotized sulfonilic acid after addition of the methanol. So this test was done with the diazo reagent. The diazo reagent, which contains sulfonilic acid in the HCl and silver nitrate in the water, the freshly prepared diazo reagent, 10 ml of the solution A, 0.8 ml of the solution B, taken in the test tube, and the color observed is estimated in the 5 nanometer is directly proportional to the concentration of the direct bilirubin. So test was done by adding 0.3 ml of diazo reagent to the 0.3 ml of serum, and if the color changes reddish purple, it shows presence of the conjugated bilirubin, and the color intensified after 30 minutes. It also shows the presence of unconjugated bilirubin. Indirectly, by adding the methanol to the diazo reagent plus serum, and color intensifies more, shows the biphasic reaction. If the directly the reddish purple color directly observed, it shows the presence of the conjugated bilirubin, and if the color dwells after adding the methanol, it shows the presence of unconjugated. By adding methanol, the unconjugated bilirubin is made to the water soluble and it reacts with the diazotized sulfonilic acids. So this is the procedure. Major causes of the increase of bilirubin levels in the blood. I already told hemolysis. If there is profuse destruction of the RBCs, what may be the cause? There is increase in the total and indirect bilirubin. Second is the failure of the conjugation in the liver. The hepatocytes do not conjugate the received unconjugated bilirubin. And finally, if there is obstruction in the clearance route of the bilirubin, that is in the bile duct, cholestasis will be there, and the unconjugated, conjugated, both types of the bilirubin recirculates in the blood. Now, urobilinogen, when the bilirubin comes into the intestine, the bacterial action converts it into the urobilinogen. Most of the urobilinogen excreted in the feces, and 20% of the urobilinogen is reabsorbed and excreted in the urine. Normally, there are mere traces of urobilinogen in the urine. And urobilinogen is the final product of the oxidation of the urobilinogen. The amount of change with the amount of urobilinogen excretion. The bilirubin is not normally present in the urine. Mostly, why? Because unconjugated bilirubin cannot pass through the kidney because of water insoluble. Only conjugated bilirubin can pass through the kidney, which is water soluble, but the conjugated bilirubin is drained into the intestine. Where it traces comes into the circulation, so very little traces can be detected in the urine, that is of a bilirubin. Bilirubin is found in the urine in obstructive jaundice to various causes and in cholestasis. If there is obstruction in the bile duct, any cause, maybe there is gallstone or other pressure due to the growth, the conjugated bilirubin recirculate in the blood, and because it is water soluble, it is passed through the urine and can be detected very easily. But in case of urobilinogen, because there is no excretion of the bile in the intestine due to the obstruction, there is no formation, though there is no supply of bilirubin in the intestine, there is no formation of the urobilinogen, and the urobilinogen is absent, totally absent in the urine as well as in the feces. So by these tests, the TSB, DSB, IDSB, urine bilinogen, urine bilirubin, fecal bilinogen, we can easily diagnose that whether it is prehepatic or hepatic or post-hepatic. In case of hemolytic type of jaundice, the TSB is increased, the IDSB is increased, the DSB is also increased, because liver has also the capacity. The total bilirubin presented to the hepatocytes, 70 to 80% of the unconjugated bilirubin is processed by the hepatocytes to conjugation, conjugated bilirubin. So in case of hemolytic, the unconjugated is, and the total is also increased, unconjugated is also increased, and conjugated is also increased. In case of urine, the urobilinogen is also increased. In fecal, urobilinogen is also increased. But in case post-hepatic conditions, total bilirubin is increased, conjugated bilirubin is also increased, but unconjugated bilirubin, that may be normal, that is not so increased as the conjugated bilirubin is increased. In case of post-hepatic, urobilinogen is absent, but there is presence of the bilirubin in the urine. So this is the picture in case of hemolytic or prehepatic, hepatic and obstructive. In a hepatic condition, due to the inflammation, there is engorgement, the function is also impaired, both the conjugated, because there is normal destruction of the RBCs. There is normal presentation of the bilirubin to the hepatocytes for conjugation. Some of the bilirubin is conjugated, some may not be the conjugated. So there is biphasic state. TSB is also increased, DSBs may also be increased, IDSB may also be increased, but to the mild level, not up to the other level. When there is profuse destruction of the cells, then unconjugated may be the more rise. Then second is the test based on liver's part in carbohydrate metabolism. These tests are not commonly done, but are the important tests for to know the function of the hepatocytes, liver: glucose tolerance test, galactose tolerance test, and fructose tolerance test. Among these, glucose tolerance test is not so important because there is other sources of the glucose is also there. But the galactose and fructose is solely converted to the glucose by the hepatocellular cells. The galactose tolerance test, normally I already told, normally liver is able to convert galactose into glucose. But this function is impaired in the intrahepatic diseases. The liver function test can be assessed by the galactose tolerance test. It is used primarily to detect the liver cell and can be performed in the presence of jaundice. The method is same as the GTT is done, glucose tolerance test. The galactose tolerance test. For galactose tolerance test, patient is fed with 50 gram of galactose. Patient should be 12-hour fasting. First sample, fasting sample is taken. Then after feeding the galactose through oral or IV route, in interval of half an hour, 5 samples are taken. And galactose is measured. This is the method. The results are in normal liver or obstructive jaundice. When there is no parenchymatic disease, the blood galactose return to normal within 1 hour. Upper normal limit in blood is taken as 160. The galactose is also estimated in the urine and normally less than 3 gram in 3 to 5 hours. In urine, galactose is passed in normal condition. But in parenchymatic disease, very high value of blood galactose levels are obtained because the function of the liver is impaired. It unable to convert the galactose into the glucose. The galactose remain in the blood. And excretion, if we estimate in the urine, the galactose, because the galactose, if it is not converted into the glucose by the liver, then it passes through the urine and estimated in the urine after 5 hours, 4 to 5 gram of more galactose is excreted in the urine. So this is the true test to test the hepatocellular function. This is the IB galactose method, the tolerance test method. In case of fructose tolerance test, the method is the same. Fructose is fed to the patient, and after each half an hour, the blood samples are taken and the glucose is estimated. The blood glucose is estimated. In normal response, 30 mg% increase is observed when the liver is able to convert the fructose into glucose. If the fasting level, if it is 70 milligram per deciliter, there is increase in the 30 mg%, that is, it may be 100 mg%. But in obstructive jaundice case, the function of the liver is normal. the fructose conversion to the glucose is taken place. The same result is obtained in most cases of obstructive jaundice cases. But in infectious hepatitis or parenchymatous liver cell disease, there is rise in blood sugar is greater than the above, because fructose is not converted into the glucose, which is utilized or converted to the glycogen. It remain in the blood. Add to the blood glucose already, and very high increase is observed. Then the test based upon changes in the plasma protein. Serum albumin, serum globulin, both are synthesized by the liver. The normal value total plasma proteins is 6 to 8 gram per deciliter. Serum albumin 3 to 5 gram per deciliter. Serum globulin 2.5 to 3.5 gram deciliter. And the AG ratio 1.2:1 or 1.5:1 in normal condition there is. Another protein, that is plasma fibrinogen, is also synthesized by the liver, and its normal values are 200 to 400 milligram per deciliter. Now estimation, BC, the total protein is 6 to 8 gram per deciliter. If the synthetic function or the function of the liver is hampered, albumin synthesis will not take place, or albumin is less synthesized. It affects both the total albumin as well as the total protein as well as the albumin. The albumin may fall from 2.5 to 3.5 to 2 or 1.5. What may be the damage of the hepatocellular cells is there. Globulins, especially alpha and gamma, are also synthesized by the liver cells. In chronic liver diseases, there is increase in the globulin, decrease in the albumin. The AG ratio reverses. The serum albumin, as shown in the slide, the most abundant protein synthesized by the liver. Synthesis depends on the extent of functioning liver cells. As I already told, the level decreases in all chronic liver diseases. I have discussed it. This is also discussed. This also I discussed. So interpretation in infectious hepatitis, early stage, albumin and globulin may be normal, but later stage there is increase in the gamma globulin, because the immunoglobulin increase in the chronic diseases. In obstructive jaundice, normal values are there. If there is no liver damage, in advanced parenchymal liver disease and in cirrhosis, albumin is grossly reduced and globulin are often increased, the AG ratio is reversed. Normally, the albumin is more and globulin is less. But in chronic stages, in advanced stages, globulin increases because globulin is synthesized in spleen also. But the albumin is not being synthesized because of liver injury. The characteristic reverse AG ratio is seen. Same is the case of with the fibrinogen. If the liver is not functioning properly, the value of fibrinogen also decreases. The normal values are 200 to 400 milligram per deciliter. Likely to be affected if considerable liver damage is present. Values fall below 100 milligram per deciliter in severe parenchymal disease. So fibrinogen, albumin, and total protein all decreases in advanced stage of the liver cirrhosis. Next, that is the test based on the abnormalities of the lipids. This is also not commonly done, but it is very important test to test the function of the liver. Normal total blood cholesterol is 150 to 250 milligram. And 60 to 70% of this is in esterified form. In obstructive jaundice, because there is no loss of function and increase in total cholesterol because of obstruction, the bile contains the cholesterol is common, but the esterification is also increased. If the cholesterol is increased, the esterification is also increased with the same ratio, that is up to the 60 to 70%. There is no change in the percentage. In parenchymatous liver disease, there may be no rise in cholesterol, but esterification is definitely reduced because liver fails to esterify the cholesterol. In severe acute hepatic necrosis, the cholesterol level is also low, where there is marked reduction in the esterification. So esterification of the cholesterol in the loss of function of the liver is definitely reduced. Then the test based on the excretory function of the liver. A very popular test, that is the BSP retention test, not routinely done. In this case, a measured amount of dye is injected intravenously. The liver removes the dye rapidly and excretes in the bile. If the liver function is impaired, the excretion is delayed and larger proportion of dye remains in the serum. It is very sensitive test and is most useful in liver cell damage without jaundice. For this test, patient is injected intravenously the bromsulfathaline, that is the BSP, and after 25 minutes and 45 minutes, 2 samples are collected. In normal condition, in healthy adults, not more than 5% dye should be remain in blood, but the bulk of dye is removed in 25 minutes. If we estimate the BSP, the most of the BSP is excreted. But in hepatic disease cirrhosis, 40 to 50% of dye retention takes place. The dye is not conjugated by the liver cells, and it can only be excreted after the conjugation into the intestine. If conjugation does not take place, it remains in the blood, and the levels of above 40 to 50% shows the hepatic disease or cirrhosis. These are the most important tests and routinely done the values of serum enzymes in the liver disorders. In liver function test, I already told the enzyme estimation is not for the function of the liver, but it detects the injury to the hepatocytes. Most commonly enzymes estimated are AST, ALT, ALP, and to some extent to diagnose another problem, gamma GT and 5 nucleotidase is also requested. First, that is the SGOT. SGOT normally present in the mitochondria. Normal range 80 to 20 micro liter per liter, and is a marker of hepatocellular damage. AST is also found in the heart muscle, liver, skeletal muscle, and to some low quantity in kidneys, pancreas, RBCs. Damaged tissue releases AST in blood. If the tissue is injured, the cells are destructed, the AST releases in the blood. AST level in blood is directly related to the extent of cellular damage or injury. Means if there is more injury, the AST levels are more high. The AST level in plasma is elevated 8 hours after cellular injury. Peak at 24 to 36 hours and turn to normal in 3 to 7 days. The AST level in blood is always high in patients with chronic hepatocellular disease. In acute hepatitis, AST in plasma is about 20 times to the normal upper limit of the AST. In acute extrahepatic obstruction, the level quickly rises to 10 times normal and quickly fall also. In cirrhotic patient, the level of AST in plasma depends on the amount of active inflammation, because in cirrhosis, the parenchyma is markedly reduced, and if there is inflammation, then only the AST levels are increased. Then the ALT. This is the more liver specific than the AST because ALT is mostly found in the liver cells. The normal range in male is 13 to 35 UL and in female 10 to 30. Appears in plasma many days before clinical signs in hepatocellular diseases. A normal value does not always indicate absence of liver damage. And obese but otherwise normal individual may have elevated ALT, that is SGPT. ALT found mainly in liver, lesser quantities are in kidney, I already told, heart and skeletal muscle. Liver injury cause elevation of ALT level in the blood. Sensitive specific indicator of the liver disease. If OT and PT both has raised, we can suspect the liver injury. But if the AST is raised, ALT is not so raised, we can suspect extrahepatic injury. Yeah, extrahepatic source of the AST increase. Sensitive specific indicator of the liver disease. ALT level is more liver specific than the AST, already told. ALT level is directly related to the extent of liver injury. Due to both AST and ALT, if the liver injury is there, AST is also increased, ALT is also increased. But in case of extrahepatic causes, AST is increased, ALT is not so increased. ALT level in plasma is elevated 8 hours after cellular injury. It not increases just there is injury. It takes 8 hours. Peak at 24 to 36 hours and turn to normal in 3 to 7 days. Same as the case of the AST. AST is released more than ALT in chronic hepatocellular diseases, cirrhosis. Because in cirrhosis, the number of functional cells already reduced. In most hepatocellular disease, more than viral, other than viral hepatitis, ALT-AST ratio is usually less than 1. In viral hepatitis, the ratio is usually greater than 1. In viral hepatitis, there is increase in the ALT level as compared to the AST. And large number of drugs can increase serum level of ALT. This is the another marker of the liver disease, alkaline phosphatase, produced by the liver canaliculi, bile canaliculi, in response to the stress due to the obstruction, cholestasis. It is also produced by the bone osteoclast for bone calcification, present on the hepatocytes membrane. Normal range is 40 to 125 UL. ALP occurs in all tissues, especially liver and bone. The alkaline phosphatase test is often used to help diagnose certain liver diseases and bone disorders. normal range 32 to 95 international unit per liter. The high levels are observed in the extrahepatic obstruction and intrahepatic cholestasis, and very high levels are observed in the bone disease. The alkaline phosphatase enzyme is not released due to the destruction of the hepatocytes. As told, it is synthesized by the cellular membrane of the hepatocyte. Due to the obstruction, due to the stress, your pressure of the bile, there is increase in the synthesis of the alkaline phosphatase. So cholestasis or obstruction is the root cause of the elevation of the ALP. There are many extrahepatic sources of ALP also. Bone is the most frequent. Newborn growth causes elevation of the ALP. The healing fractures, rheumatoid arthritis, hyperparathyroidism, placenta in case of pregnant lady. Placental ALP appears in maternal blood usually in the third trimester of the pregnancy, small intestine, kidney. So these are the extrahepatic sources of the ALP also. Another enzymes which is not routinely done, that is the 5-nucleotidase. This enzyme is released by the liver, where the liver is injured due to the bile duct obstruction, impaired bile flow. So this is also produced in case of stress by obstruction. The normal range 2 to 15 international unit. So the increase of 5-nucleotidase is also like increase of the alkaline phosphatase. If there is obstruction due to any reason, the ALP is also raised. 5-nucleotidase confirm, if it is also raised, confirms that the ALP, the increase in the ALP is of liver origin. This I discussed. Another enzymes, that is the gamma GT, gamma glutamyl transferase. It is also not commonly done, but requested in some cases. Alcoholic liver disorders. In alcoholic liver disorder, it is always elevated. Normal range is 20 to 30 micro UL per liter. Moderate elevation observed in the infective hepatitis and prostatic cancer. So there are two sources, liver and prostate. Gamma GT is increased in alcoholic despite normal liver function test. I already told, in alcoholic abuse, the gamma GT estimation is more important to know the alcoholic abuse of the patient. Highly sensitive to detecting the alcohol abuse. GGT level is very high in liver and biliary tract, but low in the kidney, spleen, heart, intestine. Already told, it is the liver specific, though it is also prostate specific. Test for GGTV is used to detect the liver cell dysfunction. Gamma GT test is highly accurate in indicating cholestasis, and elevation of gamma GT parallels that of the LP in liver disease. So the increase in ALP, to know if it is of hepatic origin or extrahepatic origin, the gamma GT and 5-nucleotidase, if these two are also have been increased along with the ALP, then it confirms the liver origin of the rise in the alkaline phosphatase, or that confirms the obstruction or cholestasis in the liver. Another test is requested, that is the prothrombin time. The pre-prothrombin is synthesized, is converted to prothrombin in the presence of vitamin K. The vitamin K deficiency also causes prolonged PT. The normal range is 11 to 13.5 seconds. It is a very good marker of liver function. If liver is not functioning proper, the prothrombin is not converted to the prothrombin, which is very important for the coagulation. PT is prolonged only when liver loses more than 80% of its reserve capacity. Measurement of the rate at which prothrombin is converted to the thrombin. The extrinsic pathway depends on the activity of clotting factors. I already told. Therefore, prothrombin time is reflection of liver dysfunction. In chronic liver disease, prolonged prothrombin time is a sign of advanced liver disease. In acute liver disease, it is a more reliable indicator of the immediate synthetic function, given it is a shorter half-life. Another test, that is the test based on the detoxificating function of the liver, the hypuric acid test. Best known test for detoxification function of the liver. Liver removes benzoic acid administered as sodium benzoate orally or IV and combined with the amino acid glycine to form hypuric acid. The amount of hypuric acid excreted in urine in a fixed time is determined. The test thus depends upon two factors: the ability of liver cells to produce sufficient glycine, the capacity of liver cells to conjugate it with the benzoic acid. The patient, for the method, the patient is fed 6 grams of benzoic acid in the form of sodium benzoate. Before feeding, the bladder is emptied, and after 4 hours, the urine is collected and estimated for the hypuric acid. Normally, at least 3 to 3.5 grams of hypuric acid is excreted in normal condition. In acute or chronic liver disease, smaller amounts are found because conjugation do not take place. In infectious hepatitis, amounts lower than 1 gram of may be excreted. It is also due to the failing of the conjugation of the sodium benzoate acid given to the patient. Then the limitation of the LFTs. Normal LFT values do not always indicate absence of the liver disease because liver has very large reserve capacity. And asymptomatic people may have abnormal LFT results. Diagnosis should be based on clinical examination also. So these are the liver function tests. This is the table. ALT is done in the hepatocellular damage, AST in the hepatocellular damage, bilirubin done in the cholestasis, impaired conjugation or biliary obstruction. ALP can be requested in cholestasis, in infiltrative disease or biliary obstruction. PT shows the synthetic function of the liver. Albumin also tells the synthetic function of the liver. Gamma GT tells the cholestasis or biliary obstruction or alcoholic abuse, and 5-nucleotidase also tells about the cholestasis or the biliary obstruction. Thank you.
थैंक यू वेरी मच सर। काफी डीप नॉलेज आज हमें लीवर फंक्शन टेस्ट का मिला। आज हम हमेशा देखते हैं कि जब भी लीवर फंक्शन टेस्ट की बात होती है तो सिर्फ बिलिरुबिन, एसजीओटी, एसजीपीटी और यूरोबिलिनोजेन के साथ साथ यूरिन बिलिरुबिन और मैक्सिमम पहुंच जाए तो जीजीटी तक पहुंचते हैं। मगर आज आपने बहुत सारे टेस्ट, नए टेस्ट जो बताए कि डिटॉक्सिफिकेशन के टेस्ट कौन से होते हैं, बहुत इतना डीप जो एग्जामिनेशंस होते हैं, जैसे हम कभी नहीं सोचते कि फाइब्रिनोजन टेस्ट भी इसमें काम में आए। पीटी आईएनआर लेटेस्ट में हम यूज करते हैं, पर उसके जो बहुत सारे बीएसपी रिटेंशन टेस्ट भी थी, ये सारे टेस्ट इतने नॉलेजेबल टेस्ट थे जिनके बारे में हमें पता होना चाहिए। एज अ रोग निदान फैकल्टी हमें पता होना चाहिए, एज अ क्लिनिशियन हमें सभी टेस्ट के बारे में बहुत डीप नॉलेज होना चाहिए। वो आज नॉलेज आपके तरफ से हमें मिला, इसके लिए हम बहुत बहुत धन्यवाद है रिसीव करते सर। गणेश सर, अतुल सर है?
नहीं
फिर कंक्लूड कर दो आप।
हाँ, कंक्लूड कर देते हैं। अगर कोई अगर सर से कोई सवाल पूछना चाहता है या कोई डाउट होगा तो पूछ सकते हैं, नहीं तो हम इस मीटिंग को कंक्लूड करेंगे। आई थिंक सर देयर इज नो एनी डाउट। थैंक यू वेरी मच सर। और एकेडमी ऑफ रोग निदान की तरफ से आपका फिर से एक बार अभिनंदन। आप अभी प्रोफेसर बने हैं सर, तो इसलिए और सबसे पहले मैंने सबसे शायद पहली बार सर को फोन किया था, तो मुझे एक बात बहुत अच्छी लगी सर की कि बहुत ही डाउन टू अर्थ पर्सन है। मैंने सर से पूछा था कि सर आपका थोड़ा सा शॉर्ट सीवी दे दीजिए ताकि हम आपको इंट्रोडक्शन कर सके आपका। तो सर ने कहा क्या करना है यार, आर्टिकल लिखते हैं तो बच्चे उसके पीछे हमारा गाइड है तो नाम चिपक जाता है। ये बहुत ये लगा सर, क्योंकि अभी ऐसी होड़ मची रहती है कि दूसरे का आर्टिकल अगर रहता है तो उसको अपना नाम कैसे चिपका दे, ये लोगों में रहता है।
इवन आज भी सुबह मैंने सर से पूछा तो सर ने मुझे नहीं बताया कि आर्टिकल, वो नहीं बताया ना मुझे। फिर भी मैं थोड़ा सा बता दूं, सर के अंडर अभी तक 10 पीजी स्कॉलर पीजी कर चुके हैं और अभी 5 पीजी स्कॉलर सर के अंडर पीजी कर रहे हैं। और मेरे तो को गाइड थे, मैं उस 10 में नहीं आता हूँ, मेरे को गाइड थे, मगर ऐसे को गाइड तो सर और तकरीबन 15-20 स्कॉलर के को गाइड भी होंगे। तो उस कारण से इतना एक्सपीरियंस होते हुए भी कभी भी सर ने ये नहीं बोला कि मैं इतना बड़ा हूँ या फिर कुछ हूँ।
जी जी थैंक यू सर।
रमेश जी,
सर के पहले स्टूडेंट भी है डॉक्टर निमिषा,
हाँ निमिषा मैम।
पहले बैच से है।
हेलो
कुछ
सर,
बोलना चाहते हैं?
प्रणाम।
हाँ प्रणाम निमिषा, और कैसी है?
सर बहुत बहुत बधाई आपको प्रोफेसर बनने की। सर बड़े दिनों बाद आपका लेक्चर